Almost there. Auntie, welcome, ma. Good evening, ma. I've been wanting to call. So, good evening, everyone. Welcome to Medical Mondays with Dr. O. Welcome to another week of learning, teaching, and all in between. I'm so excited to be here again tonight. Dr. Toyin Okwesomi, family practitioner, HIV specialist, and I treat addictions in Maryland. I host Medical Mondays with Dr. O. We're not establishing care on this forum. We are sharing current, contingent medical information to help us prevent disease entities and to know intervention sometimes when, things have happened. But we really like to prevent, to teach prevention and hopefully be able to, stop things that could negatively impact and, affect lives. Tonight, we have one of our very own, Dr. Oluwole Ajagbe, who will be our speaker tonight. I'm going to yield the floor to Dr. Ajagbe to complete his introduction and, to take it over. Thank you and welcome, sir. Welcome, everyone, to Medical Mondays with Dr. O, by the way. The floor is yours, sir.
Thank you, Dr. O. It's always exciting, really, to have opportunity to, I would say, exchange knowledge, kind of an interchange between one as a presenter as well as the listener. The listeners, asking penetrating and hard, challenging questions. So I want to welcome everybody again. Good evening. Today's topic is navigating the complex terrain of medical and dental insurance cross coverage. Now, that title itself is very mouthful, is mouthful, and it could be tongue twisting. However, we need to know that the terrain of insurance, medical and dental insurance is not very straightforward. So today, what we're going to try to do is try to look at the intricate world of medical and dental insurance cross coverage. Now, let me issue a disclaimer upfront. I am not claiming to be representing CMS, that is the Center for Medicare and Medicaid, administration. I'm not representing any insurance company, so I'm not plugging anything on behalf of any company here. What I'm trying to do tonight is let us see how we can understand certain complexities or try to unravel some of them if it's possible, because the languages, the clauses, and the terms that are written into many policies are put there to confuse. I mean, they won't admit it, but it definitely is not straightforward to a regular consumer. When you say, for instance, you are an employee, you just got a job, and your HR at your workplace say, oh yeah, we have a good insurance package for you. And they tell you, oh yeah, this one you pay only a few dollars every month from your paycheck. This one you pay a lot. And then, most people would choose the one that they pay very little. Well, that decision may have a very far-reaching consequence in the long run. You don't know that yet because you haven't read the fine print of those of that decision that you are making at that point. So what I'm trying to say to us is this: many times we make some decisions on the fly, or we base it on what some other people have told us. My insurance is the best, this and that and the other. And then you ask them, so how much do you pay for premium every month? They tell you, you open your mouth and say, no, I don't want to pay that kind of money. And well, you decide what kind of money you want to pay as premium. For insurance generally, the principle behind insurance is that the subscriber will pay very little, expecting big outcome. I mean, that is when they need the services, that the insurance will pick up the tab, no matter how expensive the services will be, whether it is medical treatment or even auto repair or house issues, any kind of insurance that we buy, even life insurance. We want the insurance company to pay more than we will invest as premium. So I don't know if that makes some sense to the listeners now, but let's try to see if we can understand and navigate, or how to navigate this complex terrain, particularly between the medical and dental insurance. So let's look at some basic stuff. So when we talk about medical and dental insurance, what do we really understand it to be? I think many of us have very little understanding of what the insurance is all about. We are told that when you buy insurance, oh yeah, you are covered. We assume that everything is covered once you buy an insurance. But unless you read your policy very carefully, you will not know exactly what your insurance policy is allowing you to benefit from that coverage. I mean, from that policy that you are buying. When the policy is made, is written out, you have 30 days usually to go over it and say whether you want to go forward with this, or you don't want, you want to cancel your policy. But many times we don't have time to read the fine print. So we just by default accept whatever is given to us, as long as we sign and they say, well, now you have a coverage. It's only when we want to do any particular type of treatment that we find out how far the coverage can be in terms of what we just paid for. So for dental is different. Dental has a ceiling for the year. In most cases, for medical, there isn't any defined ceiling. The CMS allow them to to use any kind of loophole to avoid paying, whatever it is they can avoid, but they cannot set a limit as to how much they must pay for a particular person for the year, because they don't know what the kind of, treatment that individual would need. But on the other hand, in the case of dental, since 1942, the benefit has not changed much. In 1942, the premium was like nothing for dental. But now it's hundreds of dollars to get dental insurance coverage. Now, whether you are being, subsidized by your employer, or you are buying directly, the money is not the same as it was. The premium is not the same as it was in 1942. But the benefit still remains about the same. For most dental insurance, it is $1,000 per year. That is the maximum they will pay on your behalf. I don't care how much premium you pay every month. For some dental insurance have stretched it further a little bit, like Delta Dental, and some other, third-party insurance. They've moved the dial up a little bit to 2,500, and that's like you are getting like the Cadillac of dental insurance to do that. So many people, when you don't have any major problem, it's easy. You just go for your cleaning twice a year, and you want to hear the dentist say, "Oh, no cavities, no gum disease, everything is fine." You are happy. You go home. You are continuing the home care brushing your teeth twice a day, using dental floss in between, and also making sure that anytime you have any complaint, you quickly call and get it verified and dealt with before getting worse. So for dental, it seems so straightforward from the insurer's standpoint. But for the insured, when you have a cavity that causes you pain and you have to treat that one single tooth, that's when you find out that $1,000 a year total coverage is nothing, because your first appointment may cost you about $380 out of 1,000. So you are down by 600, to $620. By the time they tell you, oh, this tooth needs to be taken out, wow, another 400 and something dollars comes to hit it. So now you have less than $300 in your account for the year. Now, if you still have another problem after that, and the $300, let's even say you have left, let's say $300, and that $300 is gone, your insurance will not pay a dime. Doesn't matter how little the problem is or how big it is done. That is where the problem is. And that's the reason why I'm coming to the table to talk tonight. To say, okay, is there any way we can navigate this? You already know that your dental coverage is $1,000 or maybe maximum $2,500. And if you're a child and they say, okay, you have a one lifetime coverage for orthodontics, and they say it's only $2,500 they will pay, which means, let's say the treatment is $10,000, you have to pay the balance out of your pocket. The guardian will have to pay the balance. Whatever way they will pay it is not, the concern of the insurance company. Because once they pay the $2,500 that they say is a lifetime, remember they say lifetime. So you can't come back in 5 years and say, oh, my teeth went back to where they used to be. I need another, braces to correct this. They'll tell you, sorry, it's done. We've covered you for one time, for a lifetime, and that's it. So if you have that dental insurance and you are very glad you have a dental insurance, and now you have depleted it within 2 or 3 appointments, so what do you do for somebody who has conditions like sleep apnea? Sleep apnea, for instance, I just want to now use that as a segue to say that some things can become a medical issue because the teeth are part of the human body. It is only in America that they try to separate the dental from the body. The mouth is part of the body. I'm talking about separating it from the standpoint of insurance coverage. The mouth is not supposed to be separated from the body because the law, the Congress and the lobbying and all of that has allowed them to continue to have this segregation between dental and medical, and it's affecting the consumers negatively long term. Until that is addressed, this problem will continue to be there. So let's say somebody has a major medical condition that can only be treated by a dental professional. So Dr. O diagnoses somebody, oh, this person has excessive daytime sleepiness. We've done a sleep study. The AHI score is 30, and this patient has severe sleep apnea, and it's obstructive sleep apnea. And Dr. O says, well, the first line of treatment that is allowed by the insurance is CPAP. Well, we already know that most of the patients that have CPAP don't use CPAP. They have the machine, but they're not using it. In fact, there's a poll that says that about 70% of the population of patients that have CPAP, which is a machine that helps to keep their airway open when they are sleeping so they can breathe, instead of stopping to breathe at about minimum of 10 times per hour, which means if they slept for 8 hours, they will have stopped breathing for about, 80 times. And 80, each time they stop breathing, they stop for about 10 seconds. So multiply 10 by 80, that's 800, 800 seconds. That's what we can say. And that means the brain is deprived of oxygen for that moment. Now, that may seem very short, but long-term effect on the brain is very devastating. And so we see the effects all around us when people have excessive daytime sleepiness. They have problem concentrating. They are very highly irritable. They are, they cannot function, particularly if they operate heavy machinery. They cannot drive for too long. They fall asleep while driving. And some of these things, we see them all around us, but the insurance doesn't want to be responsible for any of this. So if Dr. O now says, well, Mr. X has been given a CPAP for the past 5 years, but the condition is not improving. Well, the insurance will say, well, we've already done what we can. We gave the patient CPAP. But they cannot force the patient to use the CPAP. But the patient is getting worse. But now Dr. O finds out that there are other alternatives, or she already knows that there are other alternatives to help this patient. Now recommends that this patient should be evaluated for a dental, appliance that can help the patient breathe better. Now, who then navigates this for this patient? Who becomes the advocate? So that's where we need to face the discussion tonight. Who becomes the advocate of this patient? Well, primarily Dr. O will say, Mr. X, well, you are not using your CPAP and your condition is getting worse. Particularly those who have, severe acid reflux in combination with their, sleep apnea, and they also will have mouth breathing because their nostrils are also always blocked. And maybe they also have COPD. So they have all these conditions. They're not improving. And, we now know that, documented in research that some appliances are already available. They are FDA cleared to be useful to treat these conditions. I'm using the sleep apnea as one of the examples. We might look at a few more examples as time goes on. So if Dr. O has knowledge of the diagnosis using the ICD-10 code that that this patient does actually present with, these codes can be presented to the insurance company for prior authorization in order for the patients to be considered for an alternate, non-invasive, non-invasive device that can help the patient much better than CPAP. Now, the insurance will receive the prior authorization request and they will sit on it for a little bit. They will figure it out. How much is this going to cost? If this is going to cost so much, now they will go to the fine print of that patient's insurance. What policy does this patient have? Does this patient have an HMO? Does he have a PPO? Or does he have a rider on top of the policy that he bought, which was general policy? A rider is an extra money, extra premium that you're going to pay that allows you to have certain treatment done that otherwise would not be possible for you to have done under your policy. So if you have a rider, they will now look at the rider and say, okay, so, well, this rider allows this patient to have an alternate, treatment rather than the standard of care. Well, some appliances now are being defined as standard of care. So when would the insurance catch up with that? They know the information, they do, but they will not accept it quickly because they know it's going to take a lot of money out of their pocket. So they will always kind of play it safe. They will deny the prior authorization request for the first time. They will deny it. They will wish that you go away from the first denial. So if you go away, they'll be happy. They will be looking and say, just keep an eye open in case this person appeals. So they'll go and find all the armamentarium to battle that appeal. If you dare to appeal, they will then go back and say, we've reviewed the case again, and we can tell you that you are not covered. Initially they may not say you are not covered. They will just say that they denied it. They may say that they are denying it because it is not medically necessary to do that kind of procedure. Then Dr. O will go into the literature and do literature search and say, yes, I see articles here that say this is a standard of care. Then the question is, who is the advocate for the patient? So Dr. O is the primary care, but who is paying for our time? Nobody is paying for our time. So it is a difficult terrain to navigate. How many hours will Dr. O spend crafting a legitimate, persuasive appeal on behalf of a patient who may turn around not to be even appreciative of all the effort that she has made? So it's a difficult terrain, like I said earlier on, but we must try to see how we can navigate it. So now they get the appeal. They now go back to their fine print and say, okay, look here, this, and that is there in that policy. We cannot cover this patient. Now, what's the recourse? What should the patient now do? Dr. O has done her best. And the insurance still says no. Now, the patient has two options. One is to go to court. Does the patient have money to go to court? Maybe not. Because if they have money to go to court, why would they not pay for their own treatment? If they know they can afford to go to court, then they should pay for their own treatment, because going to court will make their condition worse, no doubt. Because they're not going to they're going to face adversary in court. The insurance company will come with their top gun attorneys, and they are paid. So they don't care about how long it takes for them to solve the case. So they are salaried attorneys. They're going to be there to defend their client, their employer. That's the insurance company. So for most part, knowledge about cross-coding or cross-coverage may be an advantage at this point. So if Dr. O haven't been shut down twice, now collaborates with somebody like me who has the knowledge in this area. And then we can now say, okay, we can join hands and say this is a what we call multidisciplinary approach to treating this patient. So it's no longer just being seen as a dental referral. This is a part of the treatment of this patient. So now two different professionals are backing up this patient. Remember, we have not been paid for the time that we're spending. Then we're trying to help the patient to have a better quality of life. So these are some of the things that professionals like us will do. And sometimes the patient will still not be appreciative of it, but it is something that we have to do as advocates for these patients. So using the sleep apnea still as the example or test case, if we now wrote another prior authorization request that has both dental as well as medical ICD-10 codes. Now we can justify what it is that this patient needs from the dental standpoint, that based on these ICD-10 codes, we have compatible or appropriate CPT codes, which are the treatment or procedural codes, as well as the CDT codes, which are from the dental. So we have this cross coding that goes to the insurance, then the insurance has no way of wriggling out of this problem. Because now we are saying that this patient's life is is in jeopardy if they will not cover this patient. So now they have to now draw from their reserves to support this patient's care. Without this kind of collaborative effort, the patient would never get help. If you refer, let's say Dr. O refers the patient to me, and I see the patient, I say, this is what you would need, ma'am or sir. And the patient says, well, my insurance, I have Delta Dental, and my maximum for the year is 2,500, and I've already spent 1,800 out of 2,500. But the treatment is going to cost $10,000. There's no way that patient will be, treated by me without a collaborative effort. So this is where the multidisciplinary approach to managing many of these cases can benefit the patient long term. It's a lot of work for the professionals, but if our goal is to help the patients to feel better, we can do it. Now, in the long run, we'll still get paid, for the procedures that we perform. Now, for primary care physicians, they can still have some codes that they can bill because we have what they call the billable codes. If we know those codes, we can bill, and then they would not deny them because the patient was served at that particular point in time. So let me I know this may be a little bit more, more technical if I just refer to one case. Let me just use the case of sleep apnea still. 1 second. Jaw expansion. I'm trying to find one so sleep apnea. So let's say Dr. Wu and I are collaborating on a particular case, and then we go to use the ICD-10 code, and the ICD-10 code is G 47.33, and that's obstructive sleep apnea. And I could use that code, even though I'm a dental provider. Dr. O will use the same code, but if we do it as a joint effort, then the insurance is notified that this patient needs help, and the dental approach can help this patient. So now Dr. O will put a sleep study request on behalf of this patient using a CPT code of 95806. And that goes to the insurance. The insurance will not deny that because all the pointers are there from Dr. O that this patient needs this service.
That
and
code
then
is not a primary care code. We don't use that at all.
the sleep study code.
95806.
Okay. Well, you find whatever code works from the primary care standpoint to request for sleep study, particularly the unattended one, like home care, home sleep study, like the sleep ring and stuff like that. Insurance companies are paying for that. Okay, so now let's say you put the right code and they approve it, the patient gets the sleep study done. And after the sleep study is done, we confirm that this patient really needs an oral appliance. So now I will send the prior authorization request for CDT code 9946, which is the oral appliance therapy for sleep apnea. This does not go to dental insurance because the dental insurance doesn't have this code as part of what they cover, because they know the pricing for this treatment is way ahead of what the annual limit for each patient is. So it's not acceptable for them as a covered benefit for a patient. So now we send this to the medical insurance. The medical insurance will see it as an alternate to CPAP, because this is a non-invasive approach to treating the same medical condition, but by a dental professional. Now, we don't want to go into the details of that, but the definition of a physician does not stop at those who had MD. It includes other professions that are called physicians because of their care for the patients directly. So, so once that is gone to the insurance, they will review it and say, rather than giving this patient CPAP that she's not using, let's give approval for this appliance. And so that's the one way that such appliance will be approved by the medical insurance, and it will be done by a dentist, because this is not a procedure that a primary care physician or even a sleep doctor can do in their office. So that is just to use one case to kind of show you how collaborative effort can help navigate the complex terrain of medical and dental insurance. Now we can use some other cases like TMJ problem and dental implants and jaw expansion, maxillofacial orthopedics. All of those are done by dental specialists, and they are covered by medical insurance. So at this point, I will stop. I know there will be a lot of questions, so that will give us enough room for us to be able to go into other areas that I may not be able to, I didn't address while just giving an introductory presentation. Thank you, everyone, for your attention. I think the floor is now open to questions.
Thank you very much, Dr. Ajagbe. I'm sure on this forum, our regular Medical Mondays family will wonder, why are we talking about insurance? This happened because Dr. Ajagbe talked about the life-saving jaw expansion procedure that is non-invasive, that is done to help people treat sleep apnea, but it is not cheap. And insurance, as far as we know, don't cover it. Dental procedures and dental care, as Dr. Ajagbe has presented, is a challenge in the United States because beyond cleaning, I don't know if much is covered beyond then with even the best dental insurance. So basically what I've learned in this presentation is that, a dentist can bill the device needed or treatment needed that is very expensive as a medical condition, or using a medical code to bill, because we use codes to bill in medicine. I didn't know that, and I didn't know a dentist could do that. So that's a way for people who have insurance. So my question, Dr. Ajagbe, did that summarize what I learned? Is it correct?
Yeah, basically, yes, you're right. Mm-hmm.
So, but what about those who don't have insurance and they need this intervention that you talked to us about?
Okay. So there has to be a payer for the treatment. So the insurance companies, whether they are government insurance companies like CMS or Medicaid or states, they are called payers. So these payers have rules that are set by the CMS. So if somebody does not fall under that category of being insured, then the only alternative they have will be to pay out of pocket. Now, if it's an emergency and they go to an emergency room, and while they're in the emergency room, they finally found them a caseworker or social worker who can now apply on their behalf, to Medicaid or whatever governmental policy that is available to them. Well, then they will begin to benefit from it. Otherwise, the only alternative for somebody who's not insured is to be self-insured, basically. They will pay out of pocket.
And that brings us back to the conversation we were having before, that the procedure is, I think is over $7,000, correct?
It's $10,000.
It's $10,000.
Mhm.
So not many people will have that to just pay to expand their jaws, was the conversation we had. So I was hoping that you would have found, something to present to us that could assist those who don't have insurance. And even with
Well,
insurance, it is not guaranteed that you will get the insurance to cover this. The most likely,
absolutely. Well, looking in the literature, looking everywhere, you will not find any recourse for somebody who doesn't have insurance. If you don't have insurance, which is like a safety net, that's why the government has its own that they want to control, and then they leave room for a third party, which is like Blue Cross, Blue Shield, Aetna, and all these different companies are springing up because they know it's a big business, and they're not running this to at a loss. They don't want to lose. They want to make billions of dollars in profit every year, and that's the reason they cut all of these costs, whichever way they can. They come up with new policies. So there is, I think, with Obamacare. I'm not an expert on Obamacare, but I think what the government was trying to do was to try to make sure that everybody has at least one type of insurance or another. Now, it's only when you read the fine print that you know whether you are really, being insured or just paying your money and wasting your money, because there all kinds of loopholes came out during the Obamacare, proponent. So I don't know of any other alternative unless there are philanthropists who have some funds which I'm not aware of that are specific just for treatment of patients who do not have insurance. Now, if anybody has knowledge of such foundations or philanthropic organizations, that would be a good thing to pass on to the community so that they can benefit from such generosity.
I don't know of any.
Well, I mean, there might be some people listening to us now who know, because there are all kinds of generous um, avenues out there that people are being helped.
So that being said,
I think that the question is, what kind of insurance do you accept? Because there are something credit. There are different insurance. I mean, not insurance, like a payment plan that they advertise on TV.
Oh, yes. Okay. Yeah,
Yeah.
okay. That's an alternative. Thank you for bringing that up. Well, it's a special credit system that is allowable for uh, dental or medical treatments. You have care credit. You have Paramount. You have quite a few of them now. Since COVID, there's a mushroom growth of all kinds of payment plans that have been coming up just specifically for medical and dental treatments. The way they work is they will the dental or the medical procedures that are not covered by insurance or that they don't have insurance coverage for will be billed or will be prioritized by the payer, which now is a credit company, who will say, okay, so this treatment is going to cost. I mean, the fee for this treatment is 10,000, for instance. Now they will look at the patient's credit record, and they will say, okay, we can actually pay for this treatment for you, and you will not pay any interest. Some of them will have no interest payment, and some of them will say you only pay about 2-3% uh, interest on the loan. So what they do is they will charge the dentist or the physician a percentage of that fee, and then they will get their money back from the patient. So that's how they make money. For the dentist and the physician, you get paid for something that you will not otherwise be paid for. So you don't mind, you say, well, 10% of 10,000 is 1,000. Well, I'll give her 1,000 just to be able to collect 9,000. So that's the reason why such care credit and Paramount and all those companies are still surviving. But the percentage that they take from the provider is too high. So to answer Dr. O's question, that's another alternative. If the person who is not insured doesn't have cash, they can still get the treatment done, but they will have to be paying instrumentally to a third party credit company. And of course, some people who have credit cards, they can use their credit cards for such treatment as well. Now, I think the savings account that the government allows people to do for medical treatments also is something that can be leveraged. In which case you can save towards that over time, and then once you have your money, then you can go for the treatment. Now, if your question, Dr. O, was on behalf of those who have no job, no insurance, no nothing. Well, the government has a way of covering those ones. There's a safety net for those who are unemployed.
No, they're on Medicaid, and Medicaid does not cover this at all. And many Medicaid programs do not cover dental care. In the state of Maryland, Medicaid is different.
I agree with you. But DC, on the other hand, is a Medicaid haven or heaven for people who have dental problems. Let me blow your mind. Do you know every year they have at least $100,000 for each of their Medicaid subscriber? Just put aside for their dental care, $100,000 for each individual. So while the dental insurance is putting $1,000 or $2,500 as maximum, DC government is putting $100,000 for their residents. It's topped up every new year. Once the year rolls on, and then they are recertified, they qualify for that Medicaid, they still get that 100,000. And then they have 99 different body services that they assign money to. 99 services, including orthopedics, orthotics, chiropractic, everything possible. That they have them 99 items that they have money allocated to for their residents.
That's fantastic. In DC.
In DC, yes.
Maryland next door does not have that. So
Wow.
a lot of Medicaid plans, there are Medicaid plans that do not cover dental care at all. There are some that cover just some things, but definitely nothing on the level we're talking about, not in the state of Maryland. So that is state by state. And, I've always wondered when people work, pay taxes, and have to pay for insurance, pay copay every doctor they have to see, and deductibles every doctor they have to see, and insurance does not kick in, until they have paid so much for their insurances. But then you have people who never worked or decide not to work or are working, they're making so much more money, but I don't know how they get Medicaid because they're going on cruises, they carrying all these, expensive bags and shoes, but they're on Medicaid, taxpayers' money, and getting all these freebies. I don't understand the system, but that's on the side. I couldn't help myself, but mention that. So Dr. Motoshaw in the chat box asked, he said, dental crown, which is covered by insurance, but only available for replacement by some insurances after every 5 years. Is there a way to reduce the number of years so that people can have the dental crown sooner if they need it, is what he's asking. And he also, as a follow-up question to that, cleaning is only good for 2 times a year for insurance coverage. Why is that? That is true. I just had my cleaning. I was told, you come back in 6 months. I'm like, okay. Why is that?
Well, Dr. Motoshaw, I don't know whether you're talking from the New York, right? Is it the same Dr. Motoshaw from New York?
He's in New York, yeah.
Okay. It's nice to see you join us today, Dr. Motoshaw. Welcome.
He always joins.
Anyway, the question you are asking is the question that should be thrown to the Congress. Why did they allow the insurance, the dental insurance to go rogue, to the point where they basically just wriggle out of responsibility as quickly as they can? Who are their lobbyists? I mean, who was able to lobby on their behalf since 1942 till now that is still getting them that same kind of situation? Their premium is not pegged, but their benefits is pegged. How is that? So they keep the same premium. I mean, they keep the same benefit or a little jacked up just by a few change, but the premium keeps going up. So it is not the dentist. If this will address Dr. Motoshaw directly, the dentist is not the one deciding when the crown should be done. As far as the dentist is concerned, you can come and be changing your crown every month. I mean, they will be making money. But if the insurance says from their own accrual calculations, for them to be able to make profit, they can only support you once every 5 years for a crown. Well, that's still very generous of them. Some of them will say for 15 years. So what are you going to do? Because literature supports that a crown, when it's done, can actually last about 15 years. So if an insurance company reads that article and says, this is what we're going to go by, you can't do anything about it. So then the second question of twice a year, I don't know whether there's any formula for that. I think it's just, I will call it an arbitrary stuff, arbitrary number, because it doesn't have, I don't see any scientific backing for twice a year. Because if what we are doing is to remove things that can cause damage to the gums, many people form calculus or tartar buildup within 1 week, within 2 weeks. So if Dr. O just did a cleaning, if within 3 weeks he already forms tartar buildup in her mouth, then it means she could be going on for the next 2.5 months. I mean, 4.5 months or 5.5 months before having that tartar buildup cleaned, which then can damage her gums and the bone resorption or the bone loss that cannot be replaced. So, I mean, unless the masses or the consumers fight for this, the providers can't fight for it because they will just label us that we just want to make more money. That's why we're talking about it. So the consumers like Dr. Motosho will now call their congressman in Washington and say, listen, who does this? I mean, who allows this? And the congressman says, hey, that's a good point. We'll look into that. And they look into it, and then they write up a bill. And the dental insurance is not sitting idle. You know that. They have their own lobbies too. Who will tell them? Somebody will snitch, tell them, oh, there's a bill coming up the pike. And it's about you guys. We're about to cut off your, cash cow. So you better do something about this. So they will do their own due diligence too to fight whatever the consumers are fighting against. So, this America is a good place and it allows everybody to voice their opinion. But whether your opinion is going to carry in the end, they give you a chance to say your mind. But it's not the problem of the dental professionals as to how frequently a crown should be or how many cleanings somebody should have in a year.
Thank you so much. It is because I've always wondered that is that a medically supported position? Is that why you can't get too many cleanings or stuff like that? Thank you so much, Dr. Mostosho, for that question. Dr. Booker, you have a question?
I was just going to make a comment. The cleaning is twice a year, 6 months apart. So if you go in September, you wouldn't get twice a year. You have to go, it's twice a year, 6 months apart.
Yes.
So you have to go early in the year and late in the year.
Ah. So if you go in September, that will satisfy that year.
That would, yes.
Insurance will run out at the end of the year.
Yes.
Well, what you have to understand is
Thank you.
The insurance, thank you, Dr. Buka. The insurance company counts the days. If you don't, they do. They look at the date when you had your cleaning done last. If they get any claims that is 1 day short of 6 months, they would deny the claim.
Yeah, I get that. Same with physical.
So that's the way they work it out. So you can define twice a year the way you want, but if you miss 1 day short of 6 months, no matter what date it is, they will not cover you. They will look at you and say, sorry, denied. But most of the time, the patient will not know that the insurance has denied it. is the dentist that would face that loss because the patient has already been seen.
Mm-hmm. It's true. So I have this is a comment that some people know the loopholes in the system to get government insurance. Yeah, I don't understand it. That's true. Dr. Motosho followed that to get a special crown, you pay out of pocket. Insurance does not even cover that. Are you aware of dental tourism to Turkey by young African American because of insurance restrictions?
Well, the medical and dental tourism is not new. It's been going on. People have been going to El Salvador, they've been going to Peru, they've been going to Nicaragua, they've been going to different part of South America and Central America to get their treatment done. In fact, a lot of the immigrants who are of Hispanic heritage will go back home to get their dental work done. And when they fail, when their treatment at home failed, then they come to people like me. Oh, I was, where did you get this done? I did it at home. Okay, well, this is done differently. Because we don't want to shoot anybody on the foot. We just tell them, well, if you want to correct this, it's going to cost you a lot of money but if you want to remedy it, using the same approach, you have to go back home to where you get it done.
Yeah.
So if people are going to Turkey and they have good, they have, some of the places have very good dental treatment. There's nothing wrong with that. They are spending their money. They're not going to take governmental coverage from here, like Medicaid, to go to Turkey. They're going to use their own money.
Point is, it's cheaper. When you add your flight, even the hotel and the care they get there, it's cheaper. That's the whole point of reverse medical tourism. It is cheaper. And, for instance, at Luz, cancer treatment at Luz, we now have reverse medical tourism, is equivalent to what people get here. All the equipments are there and the oncologists are phenomenal, but the cost is way cheaper. So people come from all over Africa, even from Europe. People go from the US to get cancer treatment in Lagos at Luz. And, with their flight, accommodation is cheaper. Is the point here. They do that for ophthalmology also. There are Caribbean countries where I've heard testimonies that they are fantastic in eye care, laser surgeries and stuff like that, and it's cheaper. So as you said, you made a great point. It's not the doctor's place, and they won't even listen to us. We don't even have the lobbyists, unfortunately. Doctors, dentists should have lobbyists in Congress, but we don't. It's going to be up to the patients. Is going to be up to
the consumers. The consumers are the ones that elect the people in government. They're the ones to put pressure on their representatives and senators and say they are hurting us. They are hurting us bad. Well, why we need help. So that will be the only push from the consumers.
Yeah.
Sorry, Dr. O. The medical AMA and the ADA, they have their own lobbying. They do.
We don't really lobby. We do. They say we don't really have it.
Technically speaking, they hire lobbyists to do whatever it is they need to do. Now, whether they are successful is a different thing. But what I'm saying is, yes, if you go to AMA, they have a separate arm of AMA that do the lobbying. The same thing with ADA for dental. So
I'll tell you,
familiar with that.
Medcar in Maryland does excellent work. with effecting change. And these are doctors, they are fantastic. I happen to belong to Medkai. It amazes me what gets achieved every year. That is not achieved at the federal level. And we're getting a lot done in Maryland through Medkai here. So I'm looking at, the level of what is obtainable and what does get obtained. Is why I'm saying we don't really have lobbyists at that.
Well, I mean, yes, it's easy to just push it aside, but they assign money. So when people are paying their dues, they have money assigned from that for lobbying and for all of this stuff.
No,
So
we are the ones who go. They will send the email and say, okay, meet in Annapolis for this. It will be dialogue. We've been dialoguing. And then all those doctors who have, clear our schedules and meet in Annapolis and go do it. Yeah, we do have some people who do other legwork, the lobbyists, but it's our doctors. And, I don't want to mention the names of our leaders there, but they do a job at Medkai.
But the issue is actually all this lobbying is more of law. If you don't know what the law says, you don't know what is allowable, what is not allowable, because there are thousands and thousands, if not millions of pages of documents where many things are lost. So knowledge is power. All I'm saying to us now is this. Anyone who will have access to all the articles on CMS website and tell me if you spend 1 hour and tell me how much you get out of that website. It's all law. They're telling you rules about this, rule about that. And in the end, if you're a consumer, I mean, I don't even know, even if you don't have any job to do, just sitting down to read on CMS. CMS is the Center for Medicare and Medicaid services for the US. They dictate the rule for all the third-party insurance.
Yeah, that's
so whatever they may not cover, many insurance will not cover it too. They say, well, I mean, we're not covering it because CMS is not covering it. So they use their standard to guide the third-party insurance. It is the loophole within their rulings, because every year you see final rule about this, final rule about that. If you don't follow through reading all those final rules, you think you know something last year. They have a final rule this year. You are totally lost from what you think you know last year. So many doctors are leaving money on the table because of ignorance of what the law says from the ruling agency, which is the CMS.
Thank you. So we have a question from Ero Okonwa. Ero Okonwa, you can unmute. You unmuted. Kindly ask your question.
Thank you. Thank you very much, Dr. O. And I want to thank the presenter today for, sharing their insight on dental care as it relates to
insurance that is not moving.
So I had the opportunity earlier on in the past decade to work with providers, and I get a sense of a lot of the things that you mentioned, the final rule and how convoluted the whole thing can be and how insensitive it can be to a good fraction of our population who, as you said correctly, are ignorant of the different things that are entailed in being able to benefit from CMS, Medicaid and Medicare programs. And in the process of working with providers on, transitioning from paper records to EMR, I realized something, that it's high time that we have an alternative model, something that's a lot more, that would benefit the average person who might not even have healthcare insurance coverage through their employer, or might not even understand the restrictive needs of being able to qualify for Obamacare, which is even more recent than, the period when I worked with the providers. With that in mind, what do you think about a model where providers are able to organize outside of maybe their hospital network, and possibly, because I did hear something recently from the founder of Dr. Connect that there's a move from going from this payee model to preventive service. And I'll be curious to know what you think about the possibility of this revolutionary way where you can be a lot more sensitive to the needs of the population as opposed to just making medical care a money-making thing. I'd be curious to know what thoughts you have as to alternative models, than what we currently see in the US today. Thank you.
Thank you for the question. I will approach it from two points. One is if the module will eradicate the middlemen, it might just be more. It will be a win-win on both sides, for the provider as well as the patients or the clients that is being served. The reason being that, imagine if you are my patient and I have an agreement with you that instead of paying to the third-party insurance, you're paying me a certain amount every month, and then all your dental care is taken care of for the year. Do you see how efficient that will be? And once you pay your monthly bill, you don't get any other bill anymore. So you have all the treatment done. Now, the stipulations will be very clear on major treatment. So this is going to be like you have an insurance that is not with a third party, but you're having it directly with your provider, which then I think they know exactly what you are going through, and that should be more efficient. That module, I think, is being looked upon. In fact, during the time of Obamacare propagation, people were trying to regroup. Providers were trying to come together to form their own managed care, if you can call it that way, so that the patient pays directly to the pool of doctors and they get the treatment they need. Well, I don't know how far that is gone, but that is one module. Now, the other module that you are stipulating, I'm not familiar with that, but I think, everything that has, if I put it this way, anything that is innovative has a little bit of traction, when people think, oh, this is going to work, and until it is being done and is being monitored over a period of time and can see whether it is reproducible or whether it's actually as profitable as it seemed theoretically. So I would like to see more about what the module that you're talking about. If you have any references to that, I will be glad to take a look at them and see, how effective it will be for us, both the providers as well as the clients.
Thank you very much for the feedback, sir.
There is a model that is already in place that, is here now. It's called the boutique medicine or concierge, and some people call it retainer medicine. It's in, I don't know any dentist doing this, but some primary care physicians do this, where the patients pay a flat fee in the beginning of the year or every month. It's like $1,500 or $2,000, something like that. And they have a specific number of patients that they take, depending on the practice. So the patients have easy access to the physician, direct line to the physician for, in-office visit and telehealth visit anytime through the year. Some of them still have insurances. Most of them actually that I know, at least, let me say 100% of patients that I know that are in this concierge or boutique medicine system have health insurance, but they use their health insurance to pay for medications or, when imagings are needed, x-rays, mammogram and stuff like that. They'll still get the referral and they use their insurances for that. But for the primary care payment, they pay one time. I actually, I've received some people in my office who tried to get me into the concierge medicine. I chose not to do it because I have a lot of Medicaid, Medicare patients, and they cannot afford this. And most doctors are not taking their insurances. Have Medicaid that is United or Blue Cross Blue Shield, Aetna. A lot of doctors are not taking them. And I'm thinking of these patients that if I go boutique or concierge, who will see these patients, then they would have, difficulty, getting into care. Some doctors will see them for a while and say, we're not taking that insurance anymore. So I still take them. And I know why doctors are not taking them, because insurances are not paying. You see the patient, like Dr. Ajagbe said, you would have seen the patients, you put in your claims and you don't get paid. You get your EOB and it comes
Zero.
Zero.
They give you 10 pages of 000.
Yes, and they send 10 pages of paperwork saying they're paying you zero. I don't understand those 10 pages of papers. You can just send one and say, you're not paying me for all that time I spent with the patient, but that's what's going on. So I'm not participating, I didn't, but that concept is already here. There are many doctors doing that. So they can put food on their table and take care of their families. But then, you have the patients have to be people of resource to be able to participate in such system, because they're still paying for insurances, and then they in this boutique that they pay the doctor.
Yeah, it's the convenience of access to care that makes people to go in that direction. I actually had that designed for my, what I call the global concierge practice, which is done, by different levels. You have them pretty much like you have gold, platinum, diamond, and all of that level. You can have different gradings like that, which then allows a patient says, okay, if I am seeing a patient that can come to my to get a dental checkup, minimum time, let's say 12 times a year, and they pay their fees up front, like you're saying, because let's say that's platinum. Then there's another level that they come 9 times a year. There's another level that comes 6 times a year. There's another level that comes 4 times a year. And then the minimum will be 2 times a year. So now you see, somebody will say, well, I'm willing to pay $3,500 for this for the year. And I know I'm going to get good service when I go there, because there's no arguments about should I pay, should I not pay. So, but then, like you said, if there's somebody is not does not have enough means, they cannot come up with that, because they have to pay for individuals of their family members within their family, the ones for the family. Yeah. So each person will have to pay their own fee. It's not going to be a family fee.
It's not a family.
Which is so which insurance can do on a different level. But it's just that there are so many. If we are on this platform are having difficulty discussing some of these things, think about what is going on in the Congress, when there are thousands of people who want they want the attention of the lawmakers, and everybody is making loud noise. And everybody is saying that their own view is important. And believe it or not, there are more lawyers in the lobbying arena than anywhere else. And who are the people crafting all the bills and all the laws that are being signed in the White House? These are lawyers. I mean, doctors cannot sit down and say they want to draft all these legislations, for the doctors. We still need some lawyers to do the work on behalf of the doctors.
Yeah. Ero Okonwa, you have any more comments, additions, subtractions? Was that helpful? I like that. Ero Okonwa. So, thank you so much for that question. Dr. Okpeyemi Adewale, all the way from London, has not slept. Kindly unmute, and I would like to announce to our Medical Mondays family that we need to congratulate Dr. Okpeyemi because he just became a consultant. It's one of our speakers on Medical Mondays. It's a faithful Medical Mondays family from Nigeria and now in the UK. And he passed his Part 2 fellowship exams and completed his residency program at OAU THC. So he's now a consultant periodontologist. It's a tongue twister for me, but Dr. Okpeyemi did that pronounce it well. Congratulations.
Thank you, Dr. Paul, for that. I must once again commend your efforts, your vision, all along over these Medical Mondays. I begin to look at the Medical Mondays as a university, and looking at the compendium of the various topics that have been treated freely over the years. It's been a very exciting thing, and I'm also happy to be part of it. So thank you very much for those contributions. Dentistry, to me, I also want to commend Professor Ajagbe now. I over time, through my career, I began to see a lot of aspects that dentistry has. I hope I won't make some people to be jealous about dentistry today, because there are many various aspects that it involves. It has legal aspects, behavioral parts, all sort of. And I would like us to actually appreciate Professor Ajagbe for this another angle. Now, concerning insurance, I know that is an area that quite a number of even practitioners, both the patients, the practitioners, the dentists, we don't really know much. It's an area that people don't really have a lot of ideas of what, a lot of knowledge about. So having opportunity to learn tonight on this platform is a great opportunity for me. So I appreciate you for that, sir. My own contribution is with respect to the lobbyists, because from what you have said now, most of the insurance for dental care, I have to be particular about dental care, because dental care all over the world, I know that it varies from one location to the other. I think the common ones that you can have is having scaling and polishing maybe twice a year. But if we consider those people that are actually putting this legislation in place, how can they bring forth more satisfactory or more coverage for dental care, and that at the same time that would be more beneficial for the dentists? Because there are many cares, there are many sort of treatments that one can access in dentistry that are, you have to pay out of pocket, and these companies know that these treatments are very expensive. They would rather give you to do scaling and polishing, but any other thing that are outside that, they won't cover it. So, and quite a number of people will not know some of all these things that the insurance company cover right from the outset. So the lobbyists, what are they? If we are to talk to the lobbyists, what are the things that we must push forward as dentists, as practitioners? And at the same time, the issue of the issue of anyway, they don't have anything to do with pricing, but I would like you to just speak to more coverage generally, so that if it, since it varies from one location to the other, can we get a more leverage to have a better coverage for dental treatment as far as our institutions, state or country are concerned? Thank you very much once again for giving me the opportunity. I'm grateful.
Thank you. And congratulations again, consultant.
Thank you, ma.
Lord continue to bless you and elevate you. This is just the beginning.
Yeah, thank you, ma. Yeah.
To celebrate you by the grace of God. Congrats. Dr. Ajagbe.
Yeah, well, I was waiting for you to finish your wrap up there. Dr. Okpeyemi, thank you for always having some interesting angle to the questions and comments on topics. Yes, what we can do is to talk to get our representatives involved, because that's where, in many countries like the US, where laws are abided by for most parts. I'm not talking about other parts of the world where the laws are on the paper, but the people just do whatever they want to do. It doesn't matter what is on the paper. So the first thing that can be done to change everything about dentistry is to remove the demarcation between dental and the remaining part of the body. Once that is removed, because I tell my patients, I said, well, I'm interested in your overall well-being, because the teeth didn't walk in by themselves. You brought your teeth with you to me. So if your whole body is not feeling well and your teeth look white, but the cause of the problem is around your teeth, then of course I can help you. But if your other body parts are the cause of the problem and is affecting your mouth, then I'll treat whatever the mouth can do, in the mouth I can do to alleviate your discomfort. So what we need to do is it's not like they don't know, but somehow the logic has been lost over the years that the mouth is separate from the body. So if people keep on believing that the mouth is separate from the body, well, you will never get any change anywhere in the world if they keep saying that. But the narrative has to change, that the whole body system is covered under medical, regardless of what is needed in that human being. Because that human being is one whole person, is not broken into bits and pieces. Yes, there are specialists that can work on different parts. Even just the head and neck alone, you have so many specialists that will work in that same general area of head and neck. So just cutting off is just like saying, okay, we're going to cut off ENT from the body. So ENT has to be priced differently from other parts of the body. It doesn't make sense. I don't know how they started separating the mouth from the body, but until they put the mouth back into the body and see the whole human being as one, the problem we are talking about will not change. Because see, the lobbyists, they know the right buttons to press, and they are pressing it. That's why, like I said, if you were following me, that the situation for the premium, I mean for the benefits, dental benefits has not changed much. Has not changed much since 1942. So if nothing has changed since 1942 much, but the premium keeps going up, then that means the lobbyists who know the right buttons to press are constantly pressing the right button. Otherwise, the consumers are the ones that should have made so much noise that all the representatives from every state and every district and every part of the country will echo the same thing, that we must reform this dental insurance. And to reform the dental insurance means we must put mouth back into the body. If we don't put the mouth back into the body, we keep separating the mouth from the body, there will not be a change. Thank you.
Thank you.
Thank you very much, sir.
Thank you. Irokomi, kindly unmute. Irokonwa, sorry, kindly unmute. And yeah, thank you.
Yeah, and to echo Dr. Opeyemi's sentiment about, how informative and educational this platform is, I second that. And especially thank you very much, sir. I mean, I have a strong feeling that you are also a professor on top of being a dentist. So the explanation you provided in the last response makes me remember a study that I came across approximately 2.5 years ago, where it said that flossing, can increase your lifespan. I'll be curious to know, A, if you think that's a fact, if that's really, something that's true. I can't really call it because a good number of people that I grew up with back in Africa, they, the concept of flossing with a pick, and a string is lost on them. So who knows how many people are meeting an early demise as a result of not flossing. So I'll be curious to know, what your thoughts are on that. And then on a more serious note, when we take into account the presence of Nigerians and other African immigrant groups who are yet to, who might not even have access to health care, but the concept of only going to the physician when they're sick is still something they carry over, with that lifestyle, of you only go to the doctor, when you're sick or when there's something wrong. I'm curious to know if you have any thoughts about maybe increasing their civic engagement right here in the US, where, supposedly, there's this land of the free and access to all these fantastic programs that they may not know of, be able to activate them as a catalyst for spreading awareness that, hey, we are entitled to, to quality, access to quality and affordable healthcare, and possibly even be the driving force for the very first time in a long time, since 1942, be the driving force for reforming, the way things are as it is with regards to dentistry and even access to more affordable, healthcare as it relates to other parts of the body. So I'll be happy to get your thoughts on that, sir.
Well, thank you very much. Let's take the first one, the dental flossing and extending life. We had a presentation on the very dangerous bacteria or bacterium Porphyromonas gingivalis, which is the main cause of all the systemic problems that arises from the mouth.
Dr. Ajagbe, 1 minute, please. Systemic problem means problems, issues that are caused in other areas of the body because they are because of the problems from the mouth. So basically, when people have issues in the mouth, it can actually destroy kidney. It can destroy the heart. It can, cause obstructive sleep apnea and stuff like that, people don't realize. So the oral health is connected to the rest of the body. So that's what that means. Just for
Okay.
we have a diverse audience, Dr. Ajagbe, remember.
Of course. So when I say systemic, I'm assuming that systemic is something everybody has heard of. But okay, the general health of the body of a person is affected by the oral health or oral diseases, if I may put it that way. So if you have an oral disease that is caused by a single bacterium, which is very, virulent, which is very dangerous, if I may use that word, in that occurs in the mouth, then if flossing can kind of prevent that kind of spread, then of course it will cause the lengthening of life of the individual who is practicing a meticulous oral health or oral hygiene at home. So if somebody sees dental flossing as a chore, then that means they do not have a clear understanding of what dental flossing is. Dental flossing is a simple way of saying removing dirt that your toothbrush or chewing stick cannot remove between your teeth. Now, if you have gaps between your teeth, it may not be the same. But if your teeth are tightly fitted together, you definitely need to floss. If you don't floss, the plaque and the bacteria that accumulate between teeth will not just go away just because you want them to go away. And if you ignore your teeth long enough, they will go away actually. So you don't want to ignore your teeth by saying, the dental flossing, I don't know how to do it. Well, learn how to do it. When people say we don't know of dental floss, well, somebody's talking to them about dental floss. So it is imperative that we learn that we learn how to keep our mouth healthy. And one of the ways to keep the mouth healthy is by flossing and by brushing. And I've said it on this platform a few times that, yes, you may have a toothbrush and not use it properly. And I may have just ordinary washcloths and I do a good job cleaning my teeth. So it's not just the instrument that you use that matters, it's what you accomplish using the instrument. So you must choose the right instrument that you can use effectively and efficiently to keep your mouth clean. I always use the same illustration to help people understand very well. If all you want to clean is plaque from your teeth, let's say you brush your teeth yesterday, today you want to brush your teeth, you should not use a lot of effort to clean your teeth because you cleaned it yesterday. I don't know what you could have eaten between yesterday when you brushed and now that will require you to use like a scorer or abrasive toothbrush to clean your teeth because you have to clean it real good. No. If you have a dish, a very expensive dish, and all you have eaten in it is moi moi. For those who do not know moi moi, this is an African dish that is made from beans that is ground and made into paste and is steamed. It will leave just a small smear in that dish. If you wash that dish immediately or soon afterwards, you don't need major effort. You can just use a paper towel with a little bit of soap and just use it to clean that dish without any abrasive effort and rinse it clean, and it will still be like brand new. The same thing with our teeth. Our teeth are basically called enamel, just like dishes. You say you want to buy expensive dishes, they are called enamels. So your teeth are just like that. And your teeth are way more valuable than the dishes. So why are you going to be very, very, very harsh on your teeth? So if all you are cleaning is just a film of cream cheese on your teeth, because that's what it looks like, what effort do you need to clean a smear of cream cheese from your teeth? You don't need a lot of effort. But if you don't brush those teeth for 1 week, now you need a little bit more effort to get rid of 7 days layer of plaque on that same set of teeth. So you need a little bit more effort. Now, if you cannot get it off at that effort, then it means they can become much thicker over time, and that's where calculus or tartar buildup comes from. So if you are flossing, for instance, if you floss between your front teeth in particular, you will never have tartar buildup between those teeth. And guess where you're going to find tartar buildup the most? In front of the lower front teeth. You put your tongue there, it's rough. Between your teeth, you know tartar is building up there. And if you have been using dental floss in that area, you will never feel that same roughness. So the tartar builds up over time. It is not there just overnight. It's not something that springs up on you because your neighbor hates you. No, you ignore your teeth long enough, all these buildups will be there. So if you floss regularly, you will not lose bone. Your gum tissue will not be torn away from your teeth. You will not have sensitivity of your teeth, and the bacteria that causes so much damage to the heart and to the kidneys and other systems of the body will not have such avenue, because they are more prominent in gum diseases. And so if your gum is infected because you are not flossing and because you are not brushing properly, well, your overall health is at risk. I hope that answers your question. So the second comment that you made, could you just highlight it again? It slipped my mind just now. What was the second comment you made?
The engagement of the African diaspora community, particularly.
Okay, all right, okay, thank you.
Okay.
Okay, so
Dr. Ajagbe, can you repeat it for our
yes,
audience?
what you're saying is there are many immigrants or new influx to America who are not aware of what is available for them, to benefit from, right? In terms of services.
Correct.
And then they do not know, that getting regular dental checkup, medical checkup is important to them.
Correct.
Because their mindset is, if it's not broken, don't fix it. If you're not sick, don't go see a doctor. Just
Correct.
Proactively, right? Okay.
Correct.
Well, first of all, they have to be here legally for them to be able to benefit a lot of things, right? Now, places like Nigerian Center is helping people who are not here legally to be able to get some kind of legality and for them to have access to some of the services available to anyone who is legally present in the US. So I would say that would be the, organizations like Nigerian Center that is in DC, I think is under Benga Ogunjimi, that, people should start from, say they're new, they don't know anything, let them contact the Nigerian Center. Maybe there are other ones for Ethiopia, Gambia, Uganda, I'm not aware of, but I am aware of the one for Nigerian Center. If you are aware of other centers, you can raise them up so that people who come from such background can go there to get similar exposure and awareness to the care that they can receive. Some of the cares are going to be free. Some of them may, eventually will cost some money. But if they are new and they don't have the resources, anything that is the government can provide to those who are here legally, I think they should be able to leverage such. I hope that answers the question.
The Nigerian Center is a good resource, and it's open to Nigerians and non-Nigerians. It doesn't matter. There are also community health centers. Community health centers all over the United States will see anybody. I was chief of medicine at one for 6 years. We are mandated not to ask about people's status.
Immigration status.
Yes. Nobody would ask about immigration status. They want to know what kind of income that person has. If they're staying with somebody, then they may not have income. The person will write a note to say that, they are accommodating them, and their office visit will be no more than, at that time, it could be, there are ways that they figure out whether it will be $13, no more than $25, and that covers everything. Believe it or not, they have 100% dental coverage, including, with that, that's what they will pay every visit they come, no more than that. That covers the physician visit, the labs, dental, OBGYN, whatever they need. And that's because these community health centers are partially federally funded. So please, anyone who is an immigrant should please go get their care there. They'll get comprehensive care. Again, Nigerian Center would direct them to places like that also.
Okay.
Nigerian
So let me add a little bit to that, Dr. O. Yes, there are community health centers. The one in Montgomery County here, I was part of for about 10 years as the coalition president or chair for the Montgomery County. Yes, this center is there. It's owned by Maryland. And they say they want to help patients. But sometimes they have all kinds of internal issues. I mean, maybe that's just unique to that time, but that patients are turned away and they cannot be seen or referred to some other places. But yes, the resources are there, and it depends on the county where you are in, and the vision of the health team that is in that county, because sometimes it could be as difficult to get care in some of this county that I'm aware of. So, but they're there. Thank you for mentioning that, Dr. O.
Well, go to Baltimore City, you get good care, and you don't have to live in that city to get the care. I don't know.
So now you have answers to those people who they may to go and check for sleep apnea there.
They can get sleep study, but they don't have access to what the new intervention and the new innovatives that you have. It's too expensive, and they don't have access to that. They will not be able to get that.
Okay, now I see that. Okay.
Yeah, and that's what I keep owning on, the price. We're talking about all of these things, Dr. Ajagbe. I'll repeat now in public that please talk to your folks to please reduce the cost so that they can make it affordable for people who have to pay out of pocket. Talk to them. I've asked you to do that. So Dr. Motosho says you should please advise if you give a direct payment plan in your office, and he is willing to chat with you offline. You don't have to go into details of that here. And I appreciate that, not to go into details. You say yes or no. Would you?
No.
No? Okay, it will still talk to you offline.
Okay.
Thank you. So this is my Auntie Susan Oshifade said, thank you, Dr. Ajagbe, for the brilliant presentation and special hints on ways around the issues as expected. You are appreciated. Thank you, sir.
Thank you, ma'am. Thank you.
So, okay, Irokonwa just posted some free or low medical care centers across the US. Please, if anybody needs that, just click on that link and it will cough up a lot of things for you. Thank you so much for doing that quick research and putting that in the chat box for us. So if you need care, medical, dental, please click on that and do that. If you live in the Baltimore area, in Maryland generally, University of Maryland actually give free dental care if they still do it. Oh my gosh. So it's the dental students, they have dental students, the program, and the dentists training the student dentists, all work together and provide free dental care no matter what you need. If you get there like 5 a.m. in the morning, I think for the first 2 patients. So people will go there very, very early in the morning, like 4 or 5, and be the first or the second, I think is the first 2 every day that they do that with. So somebody texted here, it is reduced, not free. I don't know what that means, but reduced is better than free.
I think what they mean is for most dental schools, they do have similar programs, but it's reduced fees.
So they are free. The first person or first 2 people, I think they get it free. Generally, dental care in that setting is reduced.
Yes, I think that's what the person was alluding to, probably.
If you cannot get there at 4 or 5 a.m. in the morning, you will not get that freebie. But Dr. Akitonde said Howard University also give free dental care. And I believe that. I know their director there. She has a heart and a passion to do health fairs. She's done several health fairs with me here in the US. Yeah, so I think Howard University, I think that is true. I can investigate that further also. So there are resources out there. It's just that this state-of-the-art, cutting-edge dentistry that Dr. Ajagbe has to offer is not included in all of this. And that is my pain. And that's why I brought him here tonight. And he still has not solved that problem for me.
Well, I mean, see, any new cutting edge approach is always going to be like that. And I think knowing what the companies or the inventors of new approaches go through before they can get approval through the FDA and all of that, all of the agencies, is the reason why many things cannot just be thrown back as free to the masses. So if they're going to even do anything, they will have at least recouped some of their investments, because there are investors who have put their money into this to develop such programs. So I can't, I mean, as much as we're talking about even lobbying and all of that, they cannot tell anybody that all your efforts should not bring dividend. They will tell you if you've invested some money, because some of the legislators may even be the investors in this program, and they want returns on their investment. So it's kind of complicated. That's why we call it complex terrain. It's not something straightforward where you can just say, just do this and this problem is solved. Just do that and the problem is solved. It's not like that. If it was like that, I'm sure, oh boy, I'm sure this problem would have been solved a century ago, but it's still here.
We will keep trudging on, and by God's grace, find solutions to these issues.
I think, sorry, Dr. Ho, I think somehow, I don't want to say it's a national arrogance or pride, how is Canada doing it?
Oh, Canada is
How?
not doing a great, they're not doing a good job. Please.
Okay.
The,
Okay.
the
Hold on 1 second.
healthcare system is in shambles.
Okay. Hold on before
People
you
who
say
have
that.
money come to us here, and those who don't have money die there because the line is too long. And, sometimes interventions that need to be had cannot be because, it's all free healthcare. No, they're not doing well.
So how? Okay. So the module in Canada is kind of like NHS in UK.
Yes, and NHS in UK, we have people in the UK here. That too is not a good system.
Okay, so now
It's not as bad as Canada.
Okay, so what I can say now is this: until we can find a middle ground between between freebies, 100% freebies that engenders a lot of waiting lists, and those who, and the other extreme, which is in America, where the sky is not even the limit for the pricing of any of the interventions. So,
Dr. Ajagbe, Haman wrote on the platform, big issues in UK with dentists, with many leaving NHS to private coverage only.
Exactly.
The shortage of dentists in the UK which led to very poor dental hygiene in general for the UK because of this. It is a work in progress to turn things around. He's excited, great listening to the various issues within the US. And by the way, Haman has posted for those from the UK, www.can.org.uk is an organization in the UK which deals with Caribbean and African health matters. So that is probably similar to our community health centers here. But Dr. Ajagbe, no. Erokomi, kindly unmute. We're not going to imitate that culture that is not working. Erokonwa, sorry.
Yes, Dr. Ajagbe is a very thought-provocative, guest.
Don't mind him.
There are things he says that just instills inspiration. And I can't remember exactly how he phrased it, but it made me think about something that was lingering in the back of my mind over the last 3 years. And it has to do with tying affordability of healthcare, be it, the whole system, be it, dentist, needs to economic production, perhaps maybe in the agrarian sector, the mining sector, you name it. I have a very strong conviction that the African immigrants in the US, if well organized, can build economic models where more sophisticated service delivery can be tied to some of the acquisition of raw materials that the rest of the world needs, whereby, terms can be negotiated to acquire some of the heavy-duty, sophisticated machinery that the MRIs, the, cutting-edge, things that kind of like, quickly helps the mold that you put around your teeth when you have cavities set, all that stuff that tends to be very expensive. If there's a way, if this is something that you might have pondered and maybe perhaps thought more thoroughly than I have, I'll be curious, to know if you think that's possible to institute in a country like this, the very litigious society we live in here in the US.
Well, I can't say I've thought about it exactly the way you have, but what you said just now is kind of like a kind of trade agreement in form of, what is really needed in a place on both sides. So this community needs raw material, we need a finished product. So if we can agree on certain terms on how to have this kind of exchange, I'm assuming that's what you mean, right?
Absolutely, sir. 100%.
Okay, so it still has to come to the lawmakers. The lawmakers will know what the doctors, the lawmakers have to be in terms with the needs of their people. Are they really representing their people? That's the first question that they must answer. If they are not fully representing their people, they will never feel their pain because they know they can get up, go to America and get treated. They can go to the UK and get treated. So they're not really seeing the problem in among their people. So if the real people, the real representative of the people can actually have that kind of mindset that they really want development for their own people, there are two approaches that can be done. One, they can do the bartering, which is basically what you are saying. It's a form of barter. So the raw materials from Africa comes here at a reduced rate, and then the equipment that we need comes to us at a reduced rate. And so we keep on having a win-win situation, okay, for both sides. That's one approach. The other approach will be, why don't we invent our own stuff? I mean, why do we have enough universities? In fact, I don't want to be very crass. There are more professors in Nigeria than many other countries in the world. I actually did a search on that. Nigeria was number 5 on the list of university professors. There are so many professors. What are we professing if we can't even make things that can turn things around for us? Well, I don't know. I mean, if we can continue to depend on the foreign resources, yeah, we keep getting whatever they give to us. Sometimes we want to beg for used equipment. You take it to Nigeria or to Africa. By the time it gets to Nigeria, to clear it from the port is a big problem. Not even that you don't have the equipment. Now you have the equipment, it's in your country. And the country it doesn't even care about it rusts on the dock. So how do you balance these issues that we're talking about? If we can find manufacturers within Nigeria that are manufacturing this equipment in Nigeria, the resources, we might import some things from other parts of the world, but the assembling and the making it function and repairing exist in Nigeria, we will not be having the same problem we are talking about. I mean, there's constant development here in the US. I went to a conference where, in fact, the equipment you bought last year has become obsolete this year. They're telling you, if you want to keep using that equipment, it's going to cost you more money than to buy this new equipment. So what are you going to do? Now you have two equipment in your office doing the same thing, because if you want to keep using the other one, it's going to cost you more money than to acquire a new one. So these are things that I think. So we can do the bartering if the representative of the people truly have the love of their people at heart. They can do it very well too, because I think China and the US they are doing it. I mean, head to head. They are negotiating on a daily basis and an intense basis. But Nigeria cannot Nigeria or many African countries do not have such leverage to be able to negotiate. They will come to Africa and steal things from us because it is our own people that will open the door for them to come in and take things out without even paying a dime.
I concur, Dr. Ajagbe. You've satisfactorily answered my question. I would like to yield for others to ask theirs. What I would strongly appreciate, sir, is if you'll be kind as to let us know how we can get in touch with you after today's session. I would very much like to see if we can work through the the President's Biden's newly established Africa Advisory Council for Diaspora Engagement. I think your mindset regards to option number 2 is something that we can explore. And I feel strongly that many African immigrants, civic groups need to be pursuing avenues to get R&D funding, that's available in abundance through corporations here that fund such research in universities, and many other professors, like you mentioned, who have brilliant, concepts, but unfortunately are not funded by their governments across Africa, can help unlock these resources that can help advance healthcare across the continent. God bless you, sir. Thank you so much for your feedback.
Actually,
thank you, sir. Thank you, sir.
I know who
Erokonwa.
I keep saying Erokonwa is a commissioner here in the state. So I'll connect you. You know me, I know everybody's voice. So since it's supposed to be Erokonwa tonight, I'm going to maintain that privacy, and we'll do that.
Okay, thank you so much for the comment. I want to also say that there are so many ways by which we can get things done. It is not by being afraid. I think there's so much fear going on in different parts of Africa. And that's the reason why collaboration has not been the way they should be. Even when those of us who have been in diaspora for a while want to collaborate with those who are our colleagues back home, we meet certain hostility, which is, many times I say to them, it's not founded, doesn't make sense. I'm trying to come to help, and you are being hostile to me. Why? What is this? I'm not even asking for money. I'm not asking for anything. I'm coming I wanted to help the residents. You are telling me you don't even have space. I'm like, are you kidding me? Anyway, that's just by the way. All I'm saying is this: if the mindset of our own people does not change, if we are constantly dependent on outside help, we will always have problems, because they would throw at us anything they want. And then we saw that during the COVID situation, where they had some expired vaccines shipped to Nigeria. And who was going to use this expired vaccine? And now Nigeria becomes a dumping ground for things that are useless elsewhere. It doesn't make sense. So we have to have representation from our own people who truly believe in our own people, not people who just want to get power and then collect what they can collect and go away. And that's it.
I didn't know about the expired vaccines.
Nigeria. Oh yeah, it came from Germany. Yes, it was
Nigeria
there.
does not allow any expired drugs into the country. You know that.
It was there. It was there.
Wow.
It was in the newspaper. It was in Nigerian newspaper.
Oh, okay, that is interesting.
I
missed that one. So before I yield back to Dr. Ajagbe for closing remarks, I just wanted to have a Medical Mondays moment to share something that was not kosher that I did, that was very dangerous. And I want to encourage us, please, not to do that. So I have this cord. I have iPhone and I have iPhone cords. And if you know about iPhone, they change these cords, they do all of that. So I can only use a specific type to charge phone in the car. So I have this cord. It was the only one I had to charge phone in the car. And I'm trying to see how you can see it is now cooperating. Okay, it's cooperating now. So it got bent. It got torn. Did you see that? Can you see that? That it was torn?
Mm-hmm. Move it close to your camera. Move it close to your camera.
Okay. Can you say? Oh.
A little better. It's okay.
Well, it got cut somehow. I don't know how. So I've heard that people tape these kinds of things. So I use the tape to tape it and to tape this section. But the tape came down, and as you can see, it slipped down. Oh, I don't know if you. Jeez. Why can't I position this? Okay. Here we go. So the tape slipped down from where that nick was, and I just left it there and was charging my phone, with a power bank. Even I was out of state in Houston, charging my phone with a power bank, and I smelled smoke. And I'm like, what's burning? And I kept talking on the phone, and all of a sudden I saw this smoke, looked like it was coming from my phone. So I quickly disconnected the cord from the power bank and saw that it was actually the cord right there that was burnt. It was burning. So I just want to encourage us that, of course, I texted my young bosses, and they quickly yelled at me that you never use a cord that is damaged. So when we have a damaged cord, please discard it and buy a new one. I thought taping it was good enough, and I have several chargers. They just won't charge in the phone because iPhone have changed the chargers. But these things are sold online. Please, let's be safe. Don't let's do this. I kept it so I can show it on Medical Mondays. Thank you. I was blessed not to be hurt. So, Dr. Ajagbe, without much ado, I'm going to yield to you to give us your closing remarks.
Thank you so much. As I said, as a disclaimer before I started, that this is a complex terrain, and I would not presume on knowing everything about it. I only have, practiced under the system for about 30 years. And so all I'm trying to do is just try to help us see how we can navigate this complex terrain, the medical and dental insurance cross coverage, which requires attention to detail, knowledge of coding systems, and effective communication with insurance payers. The insurance payers are human beings, okay? And unless they've experienced the problem that they need to adjudicate, they will not see what you are saying. But if a member of their family or they themselves have experienced this problem that we're trying to ask for prior authorization or for them to pay, they will have a human side of them to say, well, I think this should actually be covered or whatever, because the decisions are still made by people. The decisions are not made by AI at this point. The decisions are not made by machines. So people still will review this and say, well, based on what this person's coverage is, we should pay for this, or we would not pay for it. One thing else we need to bear in mind is this. When we submit prior authorization, I shared earlier on that if I use Dr. O and myself as collaborators trying to, advocate for a patient. If we did all of that and they still denied, we don't get any payment. We don't get paid for our time or for anything else. Now, when those things happen, let's say they even approve the prior authorization, they will always put a single line at the end of their approval to say that this does not guarantee payment for this service. I mean, I do not understand that principle. I've questioned them one-on-one. Why did you put this there? You are telling me I am treating this patient at my own risk of not being paid.
Mm-hmm.
Now you're telling me I would do a $10,000 worth of treatment on this patient, and I'm on my own when you say you are not going to pay me for this service. So, well, I have to always tell my patient, I'll say, well, this is what your insurance says. But I want to let you know that if the insurance does not pay and I've treated you, I will get paid for the services I've provided. And you will be responsible for that because I'm not working for the insurance. I did not have an agreement with the insurance on what to pay, what to treat you or not to treat you. I am a provider of services. And when I provide you with service, the payment is due when I provide the services. Okay. Now, if by stretch of, courtesy, I accept that whatever your insurance will pay is okay, that is a courtesy, not a demand, not a mandate that I have to do that. So I have to clarify that before I even start treating a patient so that they know if the insurance does not pay, they are going to be responsible for the payment for that service. Because really, if I'm opening a philanthropy and I say somebody else is picking up the tab, that's what that means. It means somebody else is paying on your behalf. If I say, I'm not charging you for this service, it means I took money out of my pocket and paid on your behalf. Because if the office has to be paid, I must pay that fee on your behalf. So we need to understand the terrain of insurance and not just assume once you say you have an insurance, then everything now is free to everything that I need is free. No, you just have to go read your fine print, and that's where communication and effective knowledge is important. You must know the details of your insurance policy before you start demanding services and thinking that the insurance will pay for it. And insurance is not a bad program. It's just that if we don't know, if there's no full disclosure ahead of time, then that's unfair because then they are hiding something that they don't want to tell us. But if they give a full disclosure and then you see it with your own eyes and you sign the dotted line, you say you agree. When it's time, they're telling you what you signed for, then you shouldn't be upset. You shouldn't now be turning around, bad mouthing the insurance company that their insurance is really bad. Why should they do this to me? No, go and read your fine print. So anyone who is just joining any corporation or employment and they're offering you free this and free that, please make sure you read the fine print and then be clear before you sign so that you don't get disappointed along the way. So by understanding the importance of accurate coding and documentation and advocacy for patients, we can ensure proper reimbursement. I'm talking to providers now, and quality of care for individuals requiring integrated medical and dental treatment will not fall within the cracks. So we need to, I think we talked about this last week, just after the presentation, that
thank you, sir.
so that we can collaborate more on, helping patients to get the best out of what they paid for.
Thank you so much, sir. We appreciate you. Thank you. Please still help us investigate how we can navigate getting that your state-of-the-art intervention. A lot of people need it at affordable rates. We appreciate you. Until we meet next week, everybody, please keep safe.